continuing on simulating an assessment process followed by treatment process, or at least simulation of the treatment process, not necessarily a full example. What we do is continue to go through the general pattern that I go through, so my large common normal assessment that is guided by the idea of being organized, macro identifies micro, and generally, very, very broadly, patient active or patient passive. A note on that is if the patient was able to bring themselves into your office, it is very likely that most things are working more or less as they should, say on the motor nerve side. So you can guess that most things are okay. You may have to examine more depending on what happens. Also, just a general note, if you look at these videos and you say, but you always do the same assessment and you're missing stuff. If you go back to my initial assessment videos or very early on in the playlist, what you'll note is that I say that I purposely leave out tests. I do it knowingly. I know exactly which ones I leave out when something isn't in my normal repertoire of tests and I need to add it in, I'm able to, such as will be the case here. So we simulate the patient coming in complaining of right ankle pain, right? So they complain of right ankle pain. We still are complete in our assessment. We still don't ignore anything. So we have you bend to your left, good, and bend to your right. And we pretend that that's nice and even. We have you on your back. Again, this is for simulation purposes. So usually when I go down to the feet, I don't purposefully assess the ankles. What I do is I assess the leg broadly without particularly mobilizing the ankles, but because the patient said that their right ankle is giving them trouble, I add in tests. So just very generally mobilizing them, and although the patient is complaining of ankle pain, right ankle pain, the right ankle seems fairly mobile, at least in an articular sense. When you find something like that where the articulation is okay, but the patient does complain of the pain, now you need to switch your conception. So what I need to do is consider, well, they're complaining of pain and both ankles are mobile in a reasonable way, so what else might be happening? Right? So now I check the leg broadly. We pretend that the hips are entirely fine. We pretend that the straight leg raise is entirely fine. So now we're getting confused and possibly annoyed. Right? It's like, well, you said your ankle hurts, but your ankle looks okay on the articular level. Your legs look okay on the articular level. But I have to believe you. I can't ignore that you have told me that you have pain. Right? So I can't just be ignorant and say, no way, there's no way that there's pain. So what I need to do now is switch my attention and my thought to what's going on with the soft tissues surrounding the ankle. So I still continue on, even though at this point, depending on how you feel in the moment as the practitioner, you're like, what the heck's going on? I can't find anything wrong with the ankle. And they say, there it is. Check the neck. Right? And we pretend that the neck rotates right fine, doesn't rotate left well. So what I want to do is get this out of the way before I put my patient in prone. The reason I want to put my patient in prone with respect to the ankle is I want to be able to check the soft tissues around the ankle. So what I want to do is be able to expose them. So I'm not going to make, and also the reason that I do the neck before I put a patient in prone is simply on account of the fact that many tables don't have face holes. So that's why I would make that choice often. Not exclusively, but often. I don't want to make a barrier choice, so I just go indirect, go till soft tissue soft, right? Then I compress, distract, shear. It's already in some mild torsion. Just go until all the soft tissue softens. I wait. I go back to the direct barrier. And then what I have you do, push your right shoulder backwards and relax, left shoulder backwards, relax. So that's relational motion. I hold the head relatively still, move the body under it by having the patient push their shoulders on it. So we're going to pretend like that's our neck treatment, retest, voila. Again, it's simulation, everything looks fine. We have you on your front. Now it's the right ankle that I'm concerned with, so my back is going to be to the camera for this. But what I do now is I expose, so I bend the knee because that shortens where it takes some tension out of the gastroc. The gastroc, the reason that does it is because it crosses the knee, so it takes some of the tension out. Now it won't be perfectly visible, so I'll show this on the other side, but I would approximate here, I would do push-pull across the tissue, right? So I do my push-pull. I could go direct, indirect. So again, moving the soft tissue in relation to the relatively still hard tissue, and then I can hold the soft tissue still, move the bone under it, and then I can also split there. So because of the angle, I'm going to show that on this side so that there's another visual for it. So really, because it was the right leg, all my work would have been done over here. But what I'm talking about is I stay nice and close, again, bending the knee so that you take some tension out of the gastroc. You can take some tension out of the soleus or just the posterior compartment generally, just by doing this, right? So you create a mild amount of plantar flexion with your hold, just by putting the foot into your elbow, kind of bracing here, push, pull. You'd identify what you needed to identify, hold the soft tissue still, hook the heel. You can move the bone under the soft tissue. You can go indirect there, you can go direct as you need. You can also basically split the gastroc, right? And in doing that, you can kind of get through that tendinous region in the medial portion of the gastroc. You can check the muscular tendinous junction in and around the Achilles. So you can kind of work really low, just push-pull across the Achilles, but you can also start to identify where the muscle begins to blend into the Achilles, and you can work there because often it'll be quite tender. So again, that just gives you a concept of how I would approach the gastroc region or the gastroc soleus region of the posterior compartment, and obviously it would be on the right. And because it's a simulation, we pretend that we did find some tension there, so we had to work on it. And we showed you how, essentially on both sides. We're going to have you flip to your back. Now what I need to do is consider the lateral compartment. As far as soft tissue is concerned, again, remembering that I didn't necessarily find anything on the articular level, which is why it was confusing and why I had to check the soft tissue surrounding the ankle. So now I go into the tibialis, essentially tibialis anterior, but not just that, a bunch of other muscles in the lateral compartment. You see what I do is I push into medial rotation, because what I want to do is expose that tissue to myself. Now, it's in a relatively relaxed position. We don't have to worry about that. Depending on the height of the patient, there's not a ton you can meaningfully do if the patient's heels are off the table. If I wanted to do this and then work through that soft tissue, you see how much the leg wiggles. It doesn't do what I want. So in order to shorten this tissue and work perpendicular to fiber direction, it's not going to work as well. I'll accept this. So I work here, I basically take a grip like this, and then I can mobilize the lateral compartment in relation to the bone and essentially across fiber direction or perpendicular to fiber direction. I can identify things there. I can then also do point work, trying to identify along the line if there's any area of that tissue that is higher tone. Again, lo and behold, we pretend that we found it. So we pretend that we had soft tissue findings that did not match any articular issue, because there was no articular issue on the posterior surface or in the posterior compartment and in the lateral compartment. So we had a complaint of ankle pain, but we did not have an articular finding. We did not have an articular finding anywhere else in the leg. We did have soft tissue findings, and we dealt with those. We also found something with the neck that the patient didn't complain about. We treated it first before going into prone. So just in case the table doesn't have a face hole. And essentially we have you sit up, and we don't have to rerun the test for the vertebral column, because as we suggested, we pretended in this simulation that there was no problems. So I've already retested everything. I don't necessarily need to retest the ankle because I didn't find an articular issue. So as long as I've appropriately dealt with those soft tissues, my next step, we're not going to do this just because it ends up looking odd on the camera, is we would have the patient stand and put some pressure on their feet and then move around on the ankle, because they are detecting something that I am not. I'm detecting no articular issue. I'm detecting some soft tissue issue, which we've dealt with, but their complaint is when they're on the ankle. So the comparative now is in the hands of the patient's subjective viewpoint, right? And we have to recognize that it is subjective at the point, and we'll see how it goes. We're not going to do that for this case, but those are the considerations. That's how it would go.